This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm T.G. Lafredo, and this week I'm coming to you from KRMC's Office of Interventional Radiology. My guest is Dr. Derek Hill. He is an interventional radiologist here. Dr. Hill, welcome to the program.
Thanks for having me.
Thank you. Yeah, thanks for having me. We're in your office, and you've been here for a little bit. This is the first that you and I have gotten to talk. I try to catch the docs when they first come on board, but in your case, you joined us in the middle of a pandemic.
Yep, I came here July 2020.
Yeah. How's it been for you so far?
I've loved it.
Really?
My family and I have really enjoyed Kingman. Never thought we would end up here, but it's been the best decision we've made.
Yeah.
Couldn't ask for a better team or a better job.
Really?
Yep.
Yeah. I want to ask you a little bit about that, some of that kind of, I want to get into interventional radiology, but, our first visit, it's, I'm always curious what the different trajectories of doctors and their careers and what takes them to medicine and what brings them here to Kingman, Arizona. What made you decide? Do you remember your initial interest in medicine as a kid?
I remember my initial interest came from a family friend who I looked up to, and he happened to be an interventional radiologist. And I didn't even know what it was at the time. And I remember telling people in the 7th grade that I was going to be an interventional radiologist. I remember getting interviewed for a newspaper in high school, and I have proof that I quoted I wanted to be an interventional radiologist. So it was just always kind of part of the plan, and it's hard to know really where it began, but it's just really fit my personality, and it's worked out.
That's really interesting. Yeah. Plenty of times doctors have said to me, I knew I wanted to go into medicine. I was good at science, but I wasn't sure. I had to go and do my rotations and kind of figure it out. Yeah. It's so interesting to me that you knew that all along.
I had planned on interventional radiology, try and keep an open mind. I had other interests that I wanted to explore, but I always just kind of came back to I wanted to do IR.
Do you think, this is another thought that kind of preoccupies me, right? Like, if you could go back and give the 7th grade version of yourself, like if you could arrange that conversation, what do you suppose you'd say to him? He'd say, I want to do what you're doing someday. Hard lessons or good advice that you might have picked up along the way. What do you suppose you'd say to that kid?
I would tell him to, keep going, that you got it right, that, you're going to love your job if you, do what you're planning on doing.
Yeah.
Yeah. It wouldn't change a thing.
Just simple. Yeah. Something to be said about job satisfaction, right? Because so many people harbor these deep regrets about different twists and turns. Like, oh, I had my chance and I missed it,
Yeah. And sometimes you don't have a lot of time to think about it. You kind of have to make a split-second decision, or over a year or two. But that's a relatively short period of time for your whole life. And I'm grateful I chose this.
You're a kid, and you're still trying to figure out who you are and how you tick, and those are momentous decisions.
Sure.
So much of the job that you do is based in technology, right? I mean, technology is a part of all medicine, right? But you guys are deep into it.
Yeah, that's one of the things I really like, is just the cutting edge technology that we get to use. And every year there's new devices that come out that we get to kind of look at and look at the data and see if that's going to benefit our patients or not. And it's evolving every year.
In your training, you ended up at the Mayo Clinic in Rochester, Minnesota. What was the, how did that happen? How did you line that up?
Yeah, so I kind of traveled the country with training. I started in Washington, at University of Washington for med school, and really just wanted to go to the best training I could get to.
Yeah.
And for me, that was Mayo Clinic for residency. So I moved to Minnesota, spent some good time there. Kind of wanted to get another, good experience that was different. And so for fellowship, I went to Harvard in Boston and spent some time there as well.
Yeah.
So I kind of went coast to coast.
And so how do you find yourself from there? You traveled from coast to coast and trained a bunch of places, and you turned up in Kingman, Arizona. How did that happen?
Yeah, so a lot of the times you get recruited by contacts you make through your training.
Yeah.
And the unique thing about KRMC is all radiologists, when I came here, there was 9 of us. All of us were from Mayo Clinic. And so just through those connections, I was recruited and had the chance to come work with great colleagues and friends that I had made through the years and people that I respected.
Were these guys you knew from Mayo? Or?
Some of them were.
Yeah.
One of my colleagues was my same year. That came out a year before me.
Yep.
While I did my fellowship, and then a couple others I had overlapped with.
Previous to that, had you heard of Kingman, Arizona?
I had heard of it because of my time at Mayo. People would talk about Kingman as being kind of the mini Mayo, because that's where people would, a good group of people had gone to work. So I had heard the name, and I knew some of the people there. I'd never been there before. It was never part of my plan to go to Kingman.
I know that Mayo has its own culture in terms of putting the patient first, and I know that presents certain challenges in the practice of medicine. How do you bring some of that culture here to KRMC?
Yeah, so I don't know how it got here, but it did, and that's what drew me here.
Yeah.
Is because when I came to interview, I could feel that.
Yeah.
The KRMC community had embraced that.
It felt familiar to you.
Maybe, from their prior connections with Mayo Clinic or the other docs had come before me, but it was here when I got here, and I just want to contribute to it.
Kingman's sort of a desert outpost, right? It's a long way to medical care out here. You're not exactly stumbling over physicians and interventional radiologists here, as opposed to Harvard Square, perhaps. So because of that, perhaps there's an opportunity for you to affect the lives of your patients more, to be more meaningful to them in their journeys.
Oh, absolutely. In those bigger communities, they have a lot of different options, different specialties that can all offer different things. And here we're a little bit more limited. Not as much as I thought. We have much more than I expected for a town this size.
Yeah.
But as an interventional radiologist, I have a very broad scope just to kind of cover the areas that we may not have covered otherwise.
Well, because this is a medically underserved area, did you find when you got here that you had to study other things or sort of broaden the services that you could offer?
Yeah, a little bit. So we offer a very broad scope of practice here. We do almost everything under the IR umbrella, which is pretty remarkable for a town this size and a hospital this size to be able to do that. One example would be when we came here, we have a lot of dialysis patients.
Yeah.
And there's a big need for dialysis care. Patients were having to travel, the bigger cities, Las Vegas or Phoenix, to get their dialysis fistulas created surgically. So that's one of the things, and this has only been around for a few years, is endovascular fistula creation. And so we started that program here after I arrived. And we've done probably 20 to 25 of those now. And that's been a service that we've been able to add to the community specifically that otherwise wouldn't be here.
So speaking of that procedure in particular, how does that work? What are you doing?
So generally a fistula is a surgically created connection between a vein and an artery in your arm to supply high flow blood to the veins for dialysis.
Okay.
It often requires a fairly large surgery, a long recovery. It takes a long time for that fistula to mature, and sometimes it doesn't mature. And the way we do it is minimally invasive. It's all through x-ray guidance and wires and catheters. And we access an artery in the wrist, and we access a vein in the arm, and two catheters go right next to each other, and they have magnets that come together. And it's a little filament that we hook up to our Bovie pen, and we basically just burn a little hole between the wall and the artery and the wall and the vein, and it creates a fistula. And the nice thing is we use the patient's anatomy. We don't have to do a big incision. When we're done, we put two little Band-Aids on, and the patient goes home the same day.
And then how does that translate to a change in quality of life for that patient?
So that patient oftentimes doesn't have the resources to travel to another city and do a lengthy hospital stay and a large surgery. This is a same-day procedure done here where they come and go the same day. The nice thing, too, is cosmetically it looks like a normal arm. You don't have a big incision with a big pulsating fistula sitting on top of your skin. So cosmetically it looks better. They mature faster and mature more frequently.
So, and these are dialysis patients.
These are dialysis patients.
And so how does that influence the dialysis treatment from that point on?
Yeah, so that point on, they are able to get dialysis. There's different ways to get dialysis, either through catheters or fistulas or grafts. The preferred method is through a fistula. It's going to last longer. You have lower infection risk and things like that as you would with a catheter.
I remember years ago, Dr. Hill, I spoke with a physician who was a cardiothoracic surgeon, and he was telling me that, we were talking about surgery and the scope of his work, and he said, remember this, because the first option, whenever possible, is not surgery. If there are things we can do to defer surgery, we want to do that. But if surgery is essential, that's what we have to do. But remember that every time we perform surgery, we're inflicting some kind of trauma on the body. In the case of open heart surgery, it's incredible trauma. And that always stuck with me, right? The way you have to do a little harm to do a lot of good. But it seems to me interventional radiology offers a much different approach to that, where you're causing much less trauma for patients.
Yeah, you're correct. I can't pretend that anything we do is risk-free. Everything has risk to it, but interventional radiology has been able to really save a lot of patients from bigger surgeries. Sometimes surgery is inevitable, but in a lot of cases, we're able to save the patient from having to go through big traumatic surgeries just with minimally invasive techniques.
Yeah. And you're treating a whole range of different conditions and maladies, right?
Yeah, we work from nearly head to toe. Really, every system in the body we work on somehow with some procedure. We do a large range of procedures. An example of something we can do to keep a patient from having a traumatic surgery, and a new technology we have here in the community is called microwave ablation.
Okay, tell me about it.
Microwave ablation has been around for a while in the big academic centers. It's been an expensive technology, so smaller communities like this hasn't been able to justify it.
Yeah.
Well, with the changing in the cost of the equipment and insurance coverage, it's now to the point where we can bring this to Kingman. We've been doing this for about a year and a half. And an example of this would be a kidney tumor that otherwise you would need to have a big surgery and have the kidney removed, called a nephrectomy, and that's a traumatic thing. What we're able to do is, under CT and or ultrasound guidance, place a small probe through the tumor in the kidney. We basically hook it up to a microwave machine and we cook the tumor and kill the tumor. It's a curative treatment. Wow. When we're done, there's a tiny little hole in the skin that we put a Band-Aid over, and the patient goes home the same day.
It's amazing.
That's amazing. To be able to cure cancer in a 20-minute procedure and let them go home the same day. It's fun.
It's amazing. And then for patients who have gone through that, for example, I know that for patients who have to go through radiology, then they're going for checkups frequently and making sure that the cancer doesn't come back. Is that a part of that whole?
Yep. So it's a similar follow-up to if you were to have surgery. You need to follow up, make sure there's no recurrence or residual disease.
Yeah.
But that's no different than if you'd had a big surgery.
Yeah.
Our recurrent rate or residual rates have been essentially zero since we've done this. Yeah. We haven't had a case yet, and the literature shows that it's about equal to surgery. So
yeah.
Not everybody's a candidate. It has to meet certain criteria and size, but
it's so interesting to me because I'm thinking if you were just, I say just in quotation marks, right? But if you were just an oncologist, you would have to know all kinds of cancers. You would have, obviously you'd have to be great, right? But that would be the focus of your practice.
Yeah.
But doing what you do and dealing with this huge, broad range of different types of maladies, you've got to know, it feels like you got to know everything about everything.
It keeps it fun because you're right. We work with oncology patients. We work with nephrology patients, urology patients, you name it. We work with that type of patient. So we need to know about that specialty and not just a little bit, but we need to understand it pretty well. And so it keeps it interesting.
Tell me a little bit about your colleagues here.
So I can honestly say that the team that we have here is as good or better than any team I've worked with in any of the big centers, which is remarkable for a city this size. The quality of nurses, our technologists, our schedulers, you name it, just top-notch people doing what's best for the patient.
Yeah.
And of course, there's my radiology colleagues who are incredible physicians.
Are you working with, speaking of the other physicians, are you working with them on cases very often, or is it kind of like you're all in your own silo with your own workload? How does that work?
Yes, we basically share a hallway. We each have our little office. We keep the door open, and multiple times a day we're collaborating on cases and kind of joining our minds together. Yeah. We have fairly complicated cases here in Kingman. Yeah. It's a relatively underserved community, and oftentimes people don't come in until disease is quite advanced. And so it takes a village, and we take advantage of that.
So, and there are times where you're looking at maybe an image and you're saying, I think I know what I'm seeing, but it might be good to...
Absolutely. And there's things that we all are good at.
Yeah.
If I'm looking at a brain MRI, I know that Dr. Fredrickson, he's the expert on that. So I'll bring him and ask him about that. Or Dr. Reber, if I'm looking at a musculoskeletal MRI. Is
that part of the culture of radiology, or is that something specific to here?
I would say it's part of the culture. It's difficult in a lot of communities, especially smaller communities like this, because there's often only one or two radiologists in those hospitals, so they don't have a lot of people to work side by side with.
Right.
Here we have 9 or 10 of us just down the hallway at all times, and so we're really spoiled that way.
Yeah. You said sometimes you'll see maybe a patient who should have gotten care much sooner, and so then you have a certain set of problems. And so is it sort of like you're hatching a game plan? You're looking at the problem and you're saying like, okay, typically I would solve this way, but it's got complicating factors. Does that sort of thing happen?
Yeah, disease looks differently as it progresses. Yeah. And that's something we're really focusing on here at KRMC is preventative medicine, getting the screening mammograms, the screening lung CTs for people at high risk for lung cancer, and hopefully getting ahead of it.
How do we do that? I know because we talk in public relations about that as well. Like, because I don't want it to sound like buzzwords, right? Like a holistic medicine and wellness as a way of life, as opposed to like, hey, okay, you have a problem, let's solve it, then go on back and don't worry about it. Let us know when. But we want wellness to be a way of life because ultimately that's good for everybody, right?
No, you're absolutely right. It's tough. I think it really comes down to education and getting the community to trust the physicians here and getting them to realize that we really do have their best interest at heart and that these systems work.
How much in your daily work, how much of it is dedicated to education of patients?
A large part of it.
Yeah,
getting them to understand the disease processes, and what we can do to fix it and how we can prevent it from coming back or getting worse.
If you're just joining us, this is Focus on Your Health. I'm T.G. Lafredo, and this week I'm coming to you from KRMC's Interventional Radiology. My guest is Dr. Derek Hill. He is an interventional radiologist here. Dr. Hill, can you talk to me a little bit about how patients come to you? And I'm sure there's a wide range, but for example, somebody goes to see a general provider with some sort of complaint, and then what happens?
Sure. So generally for interventional radiology, it's through referrals. And it can be referrals through anybody, through a general practitioner, through an oncologist, through a nephrologist. Because we have such a broad scope of practice, we really rely on referrals from all specialties. A good chunk of that also is coming from inpatients or patients that are here in the hospital or the ER.
In a normal day of work for you, how many patients or how many procedures are you doing?
It can vary. Here we have a very busy practice. I would say generally we do 20 to 30 procedures a day. Some of them are bigger procedures that last up to a couple of hours, and some are pretty quick procedures that take 5 or 10 minutes. And so a pretty good mix.
I wouldn't have guessed it was going to be such a high number.
Yeah, we go through a lot of patients. We have a lot of need here. We really have 2 main interventional rooms, but we also do interventions in the ultrasound room and x-ray room and CT room. And I basically just bounce from room to room.
That's amazing.
Yeah.
So they're getting one patient ready, you're in with another one.
Exactly.
And for a given procedure, what is your team like in there? Who do you have with you?
So generally for the more complicated, bigger cases, it will generally be me. We'll have a couple of nurses, one that's doing charting, and one is taking care of the patient with sedation and making sure the patient is safe. And I'll usually have a couple trained technologists that will help give me instruments and help me with the cases as a second hand.
Yeah, and then after those procedures, so many of them are minimally invasive and pretty simple, so those patients are generally going home that same day?
Yeah, almost all our patients go home the same day. There are a few exceptions to that, like, for example, if we did an endovascular repair of an aorta or a TIPS procedure, or a chemoembolization of liver tumors, those kind of things we keep overnight just to monitor them. But for the most part, people go home the same day.
I told you early on that I could get out of my depth in this pretty easily, right? So I did a little bit of research, and I discovered that a significant part of what you do is deals with drainage tubes, right? Sure. What is that, and how does that work?
So we can put tubes in a lot of places. The more common ones would be, if there's an infection in the abdomen coming from the colon or somewhere else that's developed a pocket of infection that's not going to go away on its own. Antibiotics can't penetrate that pocket of infection, and so they need to get that drained out. Alternative to surgical, exploratory laparotomy and cleaning them out and kind of a big procedure, we can use ultrasound or CT guidance and place a small tube kind of in the center of the fluid collection and take it out.
It's just kind of a gentle suction and remove it?
Yeah, so we generally have to leave the tube in for at least a few days until the drainage stops, and then we bring them back and check the tube, and if it looks better, then we can take it out at that time.
That's amazing. Is it generally just gravity that it will drain?
We have different bags that we can hook it up to. Some will give a gentle suction, and some are gravity. Other tubes that we do are for nephrostomy tubes for kidneys that are blocked either by stones or tumor. So we can put a tube into the kidney collecting system to drain the urine so the kidney doesn't get backed up.
And all of those would have been major procedures prior to or without interventional radiology.
Yeah. You know, one of the challenges for interventional radiology, especially in this community, is just getting the information out there, letting people know that we're here and what we can offer. Yeah. You know, people live their whole lives with these issues that they don't know can be fixed. And if they only knew that we could do that, it could be a big game changer for them. You know, an example would be, varicose veins. We do a lot of varicose veins, but there's a lot of people out there walking around with swollen, painful legs that don't know that they can be treated. And
the treatment isn't that difficult, right?
Well, it's similar to our other procedures. Everything's done through needles and wires and catheters, and when we're done, we put a little bandage on the puncture site, and they go home the same day. So
that varicose vein treatment is something that, how recent is that?
So varicose vein treatments have been going on for a number of years. We've been doing here for quite a while, probably 10 plus years, but it's a tried and tested technology that works really well, and people really have a big impact from it. Yeah,
but I guess I'm asking how long, because I keep thinking that there's probably a significant portion suffering from that and just thinking like, this is how it is. This is how it was for my parents and grandparents as they got older. I'm imagining many of those patients are older folks, right?
Yeah, a lot of them are.
Yeah, and so they probably think that that's the deal, and they're stuck with it.
Right. So just getting the information out there is probably our biggest challenge.
Yeah. That's our biggest challenge as well. But we talk, it's kind of bookends, because we talked about how much of your day goes into education, and the danger of doing well on the radio is that you get asked to come back and do more radio. Well, I wanted to close in the moment or two that we have left. I wanted to ask you. It seems to me that, as I mentioned earlier, technology is a big part of all kinds of medicine, right? But you guys are really on the cutting edge. And when you think about your trajectory in the time from when you were a student to now, and how technology has changed, and you kind of look ahead into your crystal ball, what's coming for your field of medicine? What do you foresee?
I think more methods of minimizing risk for surgery. Doing things minimally invasive. I really think the endovascular fistula creations that we're doing here are the future of dialysis. It's really only been around for a number of years, and we're the first people here in the region doing them. I really do think that's the future as far as that procedure. Who knows what's coming next year? We're always surprised at what people come up with, but there'll be more coming.
And what is the process for you for staying plugged in, for keeping up to date on all the advancements across all those different disciplines that do eventually touch on yours?
Yeah, so really just staying in touch with colleagues across the country, staying plugged in with Mayo Clinic and MGH and those resources there. Because that's really where that kind of stuff begins and kind of filters down to the communities. But yeah, just staying involved.
And those procedures ultimately end up easier and more efficient for the hospital, of course, and for patients. And so it really translates in a direct way to quality of life, it seems to me.
Yeah, I mean, that's the goal. Patient comes first. Let's get people taken care of in the safest way possible.
That is Dr. Derek Hill. He is an interventional radiologist at Kingman Regional Medical Center. Dr. Hill, thank you so much.
Thank you for having me, TG. Appreciate it.
And that is the program. That's Focus on Your Health. I'm TG Lafredo. Thank you so much for listening. Stay healthy, and we'll catch you next time.